Hi, my name is Nasir Saleem, and I'm a gastroenterology fellow at the University of Tennessee Health Science Center in Memphis. First, on behalf of my co authors, I would like to thank Gastrointestinal Endoscopy GIE for the opportunity to discuss our recent article entitled Endoscopic Transmission of Carbapenem-Resistant Enterobacteriaceae CRE Implications for Food and Drug Administration Approval and Post Market Surveillance of Endoscopic Devices. Duodenoscopes are used to perform more than 500,000 ERCPs annually in the United States. The complex design of duodenoscopes include an elevator mechanism and crevices that are difficult to disinfect and thus pose inherent risks of infectious transmission. This risk of transmission of highly resistant bacteria during endoscopy, specifically during ERCP, has received significant attention in the GI literature and news media over the past several years. Physicians, professional societies, FDA, and manufacturers have worked together to minimize the risk of infection transmission during ERCP and to make these important procedures safe for our patients. Many previous research articles have examined the microbiologic and duodenoscope design factors responsible for transmission of CRE and to avoid duodenoscope associated infectious transmission. However, my co-authors and I wanted to highlight another key area relevant to this issue, and that is the role of FDA regulation of endoscopes and the mechanisms of post-market surveillance. We wanted to provide gastroenterologists and endoscopists and other readers an understanding of the approval process that FDA uses for medical devices and the resources available to inform manufacturers and regulators about adverse events associated with their use to improve post-marketing surveillance. We obtained our data from publicly available FDA databases. Table 1 shows the FDA regulatory classification of medical devices into classes 1, 2, and 3. Class 1 devices, such as the Bravo pH monitoring system, pose the lowest risk to patients. For these, manufacturers must comply with guidelines after registering these devices with FDA. Class 2 devices, on the other hand, generally pose moderate risk to patients. Examples include duodenoscopes and automatic endoscope reprocessors used for high-level disinfection. These devices are cleared through the 510(k) pathway, also called pre-market notification. Manufacturers must establish substantial equivalence of a new medical device to an existing device, the so-called predicate device, for the same intended use that has received prior FDA approval. The 510(k) pathway is the most commonly used pre-market review pathway for medical devices. Finally, Class 3 devices pose the highest risk to patients. An example would be the lab band adjustable gastric banding system. These devices must obtain approval through pre-market approval (PMA). This is the FDA's most stringent review process, which requires clinical trials. We evaluated data reviewed by FDA to support clearance of selected duodenoscope models. We documented the predicate devices to which substantial equivalence was claimed and traced these devices back in time. In Table 2, we show the various duodenoscope models from all three manufacturers, their approval dates, and the predicate device for substantial equivalence. We also reviewed post-market surveillance studies ordered by FDA in 2015 to assess duodenoscope reprocessing. These included human factor studies to determine if representative personnel could understand and follow recommended reprocessing instructions, and sampling and culturing studies, in which clinically used duodenoscopes were reprocessed, sampled, and cultured for microbial growth. As we detail in our paper, in recent years the FDA has taken many important steps to strengthen and modernize the 510(k) pathway. Its regulatory science priorities include reducing healthcare associated infections through better understanding of antimicrobial sterilization, disinfection, and reprocessing of medical devices. However, we believe some adverse events may be unavoidable as our knowledge and clinical experience with the device grows. Relatively rare events such as CRE infections may be difficult to detect in pre-market clinical trials which may not involve enough patients or may not have sufficient follow-up. As such, devices like duodenoscopes must be monitored in real-world clinical use to ensure safety. And partly in response to duodenoscope-associated CRE outbreaks, the FDA has focused efforts on strengthening post-market safety data collection. The FDA's current post-market surveillance system for medical devices relies on two primary mechanisms: passive reporting, and for a selected minority of devices, FDA can order mandated post-market surveillance studies. First, let's discuss adverse event reporting. Medical device reports, MDRs, are maintained in the FDA's publicly available Manufacturer and User Facility Device Experience Database. Device manufacturers must submit MDRs for devices that malfunctioned or caused or contributed to a death or serious injury. Device user facilities, which include hospitals, ambulatory surgical centers, and other healthcare facilities, but not physicians' offices, must report serious injuries related to device use to the manufacturers and notify both manufacturers and the FDA within 10 working days of any device-related deaths. We believe gastroenterologists and endoscopists should be aware of adverse event reporting. Clinicians and patients can also voluntarily report suspected device-related adverse events by telephone, fax, mail, or by using the MedWatch reporting program available online. The FDA's MedWatch voluntary reporting form for health professionals, called the FDA Form 3500, is available online, and it in general requires non-identifying patient demographics, nature of the problem, and device involved. The more comprehensive the clinical data that are provided, the greater utility that the report will have to regulators. Second, FDA can also order post-market studies at the time of device approval or if any safety concerns arise later during clinical use. Gastroenterologists should and can be involved in these post-market studies to support generation of important evidence. For example, we can also work with multidisciplinary team members such as endoscopy staff to monitor adoption and practice of standard cleaning and disinfecting protocols. Improved duodenoscope disinfection and culturing techniques coupled with the use of disposable components and disposable single-use duodenoscopes will certainly help curb CRE infections during ERCP. And we believe these efforts should be the area of continued research, and which can be augmented by a more active and robust physician involvement in post-marketing surveillance. Thanks again to GIE for the opportunity to discuss our article on the FDA approval and post-market surveillance methods in the context of ERCP-related CRE infections. I hope you will enjoy reading our article. Thank you.